So this demonstration of a cat spay is to show you sort of really the sort of new graduates approach. We've done sort of the rapid approach on another video, but I want to show this one as basically trying to keep it safe for your first few cat spays. Always tie the legs back before you clip, so everything's sort of stretched out. And then the most important is getting the incision point right. So femoral head's here, pelvis end's here. It's sort of a medium-sized cat, so we're going about half a finger in front of the pelvis, going down like that. And then lumbar, gently press a finger below the lumbar, and that's where ureters live, here. So this is the area we do not want to go past, so we don't want to go past that finger below the lumbar. So the incision point would roughly be about here. Try and keep everything around 1 centimetre. And also, if you notice, it's about halfway down the cat. So if you've got one up high up here or low down here, you know, just checking on the depth regards the cat is worthwhile to make sure. So we've got our incision point now. Right, to place the drape, we're going to use one which got quite a sort of larger hole, which is quite good because it gives you more idea of everything around in the vicinity as well. So we start off with our incision. Important thing to do is not move the skin around because it'll move the marker, so you can hold the skin, press it down if you need to. And because I'm using an 11 blade, it's just more gentle pressure compared to a 15. So we're through the skin, so that's it with the blade. We shouldn't need the blade again now. So we've got iris scissors, we've got medicine balm scissors. Iris scissors are quite good for going through the muscle. So now we'll just tense up the fat. And we want to remove a fat window so we can see the muscle clearly below. Quite often I'll snip into it and just blunt dissect it like this, so it separates it from the muscle, because the common error for new grads is to actually chop some of the muscle out with the fat. So if you blunt dissect it that, so it raises the fat away from the muscle, and you can be more confident that you're not going to catch the muscle. Reason we move all this is so we don't get it mixed up with mesenteric fat later on, and to make it nice and clear. So that's our fat gone. And the most important thing with the flank is that the snips are directly on top of each other. So to achieve that, grab the muscle where we want to make the snip, which is there. So we then hold it to the left. Now if you use the Irish scissors, it tends to give you a nice cleaner snip. And then you can just open it up a little bit, but not much. And then we'll grab the internal muscle, pull that out through the external. Then again hold it to the left, so our snip should hopefully fall central. And again with the Irish you can keep a finer, cleaner snip compared to the medicine balms. So you can see there we're through the peritoneum. Always essential to make sure you're through the peritoneum. If you're not, then you'll have to tear a window through it. And we hold on to the internal muscle, pick up the uterus there. That shows our incision was the right spot. If you pick up mesenteric fat, which is this, the uterus lies above the mesenteric fat, so you go in a bit higher. That's the intestine just below, and the uterus lives just above that, so hence going a bit higher. There's your uterus, and right at the top is the fat pad here. See this fat pad? It's the lumbar fat pad, and the uterus is attached to it below. So if you find the lumbar fat pad, you just got to look below the lumbar fat pad, find the uterus. Okay, so we're going to, with this technique, we'll do the moving clamp technique, I think. So we'll place our clamp here, well below the ovary, and then we'll use uterine separation to make life easier. So we just clamp just behind the ovary, and then put another clamp alongside that. Snip between. So we've got the ovary and ovarian pedicle here, and this is the uterus here. So we separated it to make suture placement easier. Now initially I would probably do 2 ligations, 2 incisions to start with, so you feel happy with your. So we'll just wrap it around, play the clamp, just rotate the clamp. So when you rotate it, you know you're not going to get anything caught in it. Take your time. Okay, that's our first ligature. So ovary's still up here. You can check the ligature on this side, see it's tight. And now what we can do is move the clamp up a little bit more. Still clearing the ovary. So the ovary ends there. You can just sort of see it tapers to a point, so we're quite well past it. Yeah. And then we can just add another ligature. With this one, I'm going to actually attempt to put it below the first one. Or we could go above the first one, so I'm just going to do this below. It doesn't really matter if they're close together, because really what you're doing is just putting another one in case your first one's bad. So we've got our 2 single surgeons there. You don't need them unless surgeons do it okay on their own. Now the most important bit is taking the ovary off, which actually might be better with the blade because it was close-ish to the clamp. Okay, so they look fine. If you want to hold it, make sure you hold it above the ligations with non-traumatic, so you're not going to damage anything. And just let go. Now to find the other side. See this here, this is your broad ligament, non-vascular. That's actually the proper ligament there that runs near to the bladder. Quite often students pick that up, think, God, I've got the ureter. But it's not, it's the proper ligament. To get the ureters, you have to be too high up here and go into retroperitoneum cavity. So as long as your incision's in the right point, there shouldn't be any risk of ureter damage. So we're just going to clear that window. So it helps us exteriorise the uterus a bit more. See here now, we can see the other side. Now we've broken down the broad. If we couldn't see the other side, then you basically keep the uterus here and you just open your forceps in this area looking down, and you'd see it running there. So we'll just go down and pull this one up. Curved hockey forceps are good for this because they curve around. So like regards how much you can pull on the uterus, just some. It's the ovary where you can pull more because it's got the ligaments attached protecting it. So I'll make our window and we'll push down somewhat. click it. Just rotate, nothing is caught in it. No, that's okay. And then, like I say, this one we're doing uterine separation to show you different technique. So we'll just above the ovary, snip, just above that, snip. With uterine separation, if you've got a really young cat with a short uterus, then maybe it's best not to do it in case, you know, you've got like a small piece of uterus here and you could lose it. And cats with this size uterus is fine. So we've got a pedicle there where we're going to ligate. So we'll place the first, just wrap it round, ready, that. And the important thing is to rotate this clamp. See how rotation makes it so you're not going to get it caught on the muscle or the skin. Before I used to get students to do that, so many used to get the ligature caught on the skin or the fat. So rotating the clamp is a good thing to do. So our 2 and 6 ones. The first one over the surgeons is very important to be tight because that tightens the surgeons. Initial surgeons, the tooth throw can get a bounce back. So when you tighten that first one, it should then tighten the surgeons more. Okay, so that's our first surgeons. So below the clamp down here. We can place the clamp's original position, and then ovary's there, so we can then raise the clamp out there. We're still clearing the ovary, and place another surgeons. Like I say, eventually you'll just be doing 1 surgeons, but initially 2 is probably good to perfect them. And again, we'll rotate the clamp this way. And I just use my needle holders over there. So 2. So you always want to avoid getting it too close to the clamp because the tissue is obviously squashed out by the clamp. So you're not going to get a tight ligature that's biting well. So you need it somewhat below the clamp. Okay. So that's our second surgeon's done. I've lost my scissors. There they are. Okay. Now we've got the 2 clamps. Now one thing you can do with the uterine separation technique is test it this way. So I'm taking everything off, but still holding the ovary so we don't lose it. And then just check we've got no bleeding. That looks fine, so we'll replace the clamp, making sure we're clearing the ovary. And then just take the ovary off. Okay, so now we can confidently release that because we've already checked it. And this here, again, is a broad ligament, so fairly non-vascular, so we can just break it. And then we'll see where our so we can get the uterus out nicely. Now, it's fairly young cat, so the uterus is pretty sort of in a good state compared to like an older cat, so I might have a grey, fragile uterus. This one you see is quite sort of pink and healthy. So we go up to She's catgut. The reason I like catgut in the uterus is you can control the tension better of the knots. Vicryl is usually tight or loose, whereas catgut you can control it a bit, so you can sort of do it semi-tight if needed. And never do surgeons on a, never do millers on a cat uterus unless it's pregnant because of the cheese wire risk. So you can just see there it's blanching as I do it, so I'm not going to risk pulling too much and cheese wiring it. Okay, so that's our first one on. And then as we've got this one on and it all seems okay, we can go that little bit tighter if we want the next one, because we've already got one on. But again, just look for the blanching. It's always good catgut is to grab it. See, you can see there it's damaged where I've grabbed it, so grab it in a different spot to tighten. Again, place it, grab it in a different spot to tighten. If you keep grabbing it in the same spot, it will break. Same with Vicryl will do as well if you keep holding it in the same place. So move around it a bit. One more, can't remember what we've done, but that should be fine. So we've got our two surgeons on the uterus. It should be fine. Like I say, we can see the blanching, so we're quite happy they're not going to bleed. And we'll just leave some tissue behind this ligature. Some people say the golden centimetre. I'll leave probably just under a centimetre. Okay, so we'll just nudge everything back in, and now we're going to do closure. We'll do the closure with the catgut. We'll use a round-bodied needle. Now this is a European one, so it's got a hole to thread it. Try the other end. There we go. And then the second hole you can just click it in. So that keeps it in. Right, the best way to do these crochets, I always use rat tooth because otherwise I can't hold on to them. That's the external because it's most outer, so the internal's below. So just pick up your internal, get a nice bite on one side, then get a nice bite on the other side. And we can pull our suture through to that there, and we can lift it up and get our second bite. So lifting it up just makes life easier. And then we'll just put it together gently and snug, not tight. You don't want any sort of vascular necrosis of the muscle. Tight too tight, and the vessels die off, and then the flesh. Okay, so got the one piece and keep the other tail, because what you can use that other tail for now is again lifting it up and going through. Once it's through, snip that tail off, pull it through, and again lift her up. Now you've lifted her up, and the pass through, That's our second crochet. So we've got a new piece, and we'll just, like I say, do that. Just a normal, simple interrupted at the bottom of the muscle, and it's fully closed then, without getting a knot in our suture. Swab off that tail. So that's your internal layer closed. I always do them separate. To close the internal and external together at the same time, we'll leave a hole, usually in the internal, because the lengths of the snips are different. So don't really want to be doing that. You want to make it nice for the cat. Two closures. Okay, so external is just going to be above, obviously. See it here. If you can't find the external, then unfortunately it means that you've got it mixed up with the internal. And the external always looks dog-eared when you close it. You can never really make it look pretty. So I'll just put one crochet in here. And I can never make it look pretty that way. As long as it's closed, that's the most important, and it's not too tight. So that's closed off most of it. There's a little hole, so I think we're going to have to just put interrupted in. But see the difference there we've got. So people and surgeons close them both together. They're leaving a hole in the internal because the external is a lot smaller usually, the entry. Okay, so that's our internal closed, and that's really, we'll then revert back now to the 2 metric 3 knot vicryl. We'll put it on a cutting needle. I'm going to use a UK needle, it's got this one hole, and then because it's 2 metric 3 knot, we can tie it on. Anything like bigger than that, 3 metric 2 knot, you won't be able to do it because it drag through. So now one bit, load those up ready, and go and find your fat. So fat's up here. Occasionally you'll sort of caught it in the external, so you just have to sort of break it down. We want it covering the cat gut that's closed the muscle, but it's not a holding layer, so it doesn't have to be spectacularly, as long as it just covers and stops dead space and strain formation. So when you tie it off, just don't do it so it bunches up and screws up like a purse string. Just want to keep it just nice and flat, covering there. So see there, it's hard to get the other side, so you come through, do that, then use both forceps to get your fat. and then one more pass. Down here to close it. Again, nice and loose. So this is going to form the anchor for the intradermals. Like I used to worry about, well, the anchor's in the fat's not very strong, it's going to tear through. But it's the actual physical size of the knot stops it pulling through the skin. So just done simple continuous to the fat. Now, don't have to worry about hiding this knot because it's sort of below the skin level quite well. I usually just go out, come out, just grab a slight bite subdermal and come out in the intradermal position. And now start your intradermals. I always use my rat tooth to stretch the skin. If I don't stretch the skin, I cannot do it. Remember, literally just going sideways through the skin. So the skin's there. I'm just going sideways. Obviously, the thinner the skin, the harder it is. And then always just check you haven't come out. You haven't come out on the other side here. It's easily done within the skin like this. So again, stretch the skin. Bite through the skin, sideways without coming out. I think some people refer to them as transdermals. I think that's a better name than intradermals because it's going through the skin. So let's check that one. That one's come out. You see there, it's come out. So I've got to go again. It's hard once it starts coming out. It just keeps on doing the same thing. So I'm just going to go a little bit lower with a shorter grab. I've got away with that. Back to the other side. You always tend to find one side goes through easier than the other side, like the top side's easy, the bottom side's harder here. Again, it's gone through. So I've pulled it out. That's too weak a bite. Oh, that's gone through, that's very... So I might have to go a bit deeper. Yeah, so I've gone deeper, quite out superficial. So it's got a last bite at the top. I usually go back to where the last needle came out, so that should be right there, the last bite. Now I'm tempted to tie it here and use that little hole there for burial. Right, surgeons versus Aberdeen. Surgeons are far stronger and you can control the tightness, so I personally prefer them. If you're going to do an Aberdeen, when you finish it at the end, when you pass it through, you need to pass it through round and pass it through again to stop it falling to pieces. but you'd be surprised how many Aberdeens fall to pieces. Yet we keep doing them. So we can control the tension on that nicely. And then I just continue with the surgeons. Each sort of throw, we know it's tight, whereas the Aberdeen you can get little gaps sometimes, again making it weaker. I tend to do quite a few throws, I've lost count already. Okay, so now you can see here we've got the knot and we've got the tail. The essential thing is you leave no tail behind, because that will not pass through the skin. So often I'll put sort of 8 throws on and cut the tail so short like that. And then the secret is, if your needle glides through, your knot should bury. So I'm just probing this area here. There's my needle, and it just seems to pop through easily there. So I'll go with that. Pull load the skin over the needle, and then pull on the suture material, but also push on the skin. Click as it goes in, and we want the second click as the whole knot goes in. There you go. And see how much more secure that is closed with the surgeons. But one thing will suit me, but it won't suit somebody else. So we're all different. So you do what suits you right. There we go. And we see how we sort of kept it within the centimetre incision. So we shouldn't expect any post-op problems with that. So now we'll just clean up, put a little bit of aluminium spray on because it's a street cat.